still observe, because in a good vision, the complication associated with VR surgery, we don't do the surgery. If optic dispute maculacy with NSD with decreased visual acuity, patient is complaining and the patient requires surgery, then after convincing the surgery, we do the treatment, whatever it is. It may be in the form of laser or vitrectomy. Natural course, mostly 25 to 75 progression to the maculopathy. So laser is one of the treatment which has been advocated. We have also seen in some cases the result, but we are not 100% sure. So at present, literature doesn't says we should do the laser, but one or two reports says the laser will decrease the fluid and will cause complete resolution of the NSD. With gas and air is another modality, but at present, what we are doing is a vitrectomy with PVD induction without ILM peel, because ILM peel is not considered, because if you have to do it, you have to do the macular sparing because of the complication of macular hole. And in these cases, success rate is 50 to 60% and may take greater than 12 months for fluid absorption. Complete resolution is very, very rare. Decrease in the height takes more than 1 year. Vitrectomy, then the another thing is, the another thing is people have started stuffing of the optic pit, because source they consider the optic pit. So we must close the optic pit. So stuffing is the next line which people are doing, in which various tissues are used, like scler tissue stuffing. So this, I will show you the one case where initially there was a patient presented with just macular cysts, region wise 6 by 6. And you see after 1 to 2 year region is still 6 by 6. There is no NSD. Again, 20, 22. There is no metamorphosis. Vision is all right. Now here is the come after 3 years. Patient has developed 6 by 6 pars vision, still asymptomatic. Now you do 6 by 6. Now at this time, vision is 6 by 9 in August. The NSD, neurosynapse detachment, increased, and patient has a vision of 6 by 9. Now this is 6 by 9 pars. At that stage, patient was convinced. Then the vision by 6 by 12. This is after 5 years of follower, when vision by 6 by 12. So as you can see, this is just a plasma vitrectomy with not stuffing. Simple plasma vitrectomy, PVD induction, and nasal side ILM peeling only, macular sparing ILM peeling. So you can see the thickness has decreased from 677 to 507, and vision is 6 by 9. Now, if you see the total, in this case, October, this is the height 871, and after 1 year, around it has decreased to 307, and vision is 6 by 6. Now you see after this recent photograph 1 week back, the NSD has recovered, the small amount of fluid is still present, but vision is 6 by 6, patient is asymptomatic. So it takes more than 1 year in the resolution of the fluid if we do simple plasma vitrectomy. So this is the flow diagram we take. So this is another case which I would like to take, because another source is optic CSF. So people are advocating stuffing of the optic pit with the various materials like ILM or the scleral tissue. So in this case, we have done the plasma vitrectomy. ये चल नहीं रहा, इसको वहां से डाउनलोड कर, उधर से डायरेक्ट डायरेक्ट वही आ जाए है, नहीं इसके अंदर है ना. So here we have done the plasma vitrectomy, PVD inductions, and the scleral plug was taken from the sclera, and small piece with the forceps we have tried to insert directly inside the optic pit. इधर रखा हुआ इसके अंदर है, डायरेक्ट डायरेक्ट वैसे ठीक कंप्लीट. So watertight closure is very difficult to achieve. So people here, this, can you see? Parijat, can you see? No.
It's not moving, sir, actually.
Now? Acha.
It's not moving, sir.
So everybody has seen these. Just so various plugging material has been used like ILM and small plug, and some people have used the amniotic membrane. Can you see?
Now it started. Now it started.
Okay. So this is just simple vitrectomy, and then this small plug, which was taken, and with the forceps this was put over there. The only thing is in this case we have done the PVD. We have removed the vitreous traction, which people think is this causing the traction, causing the leakage fluid in the subretinal space. And by plugging the optic pit, we are closing the second source, that is the cerebral spinal fluid, or the fluid coming from the subretinal space. So one thing we have seen in these cases, resolution is very fast. In this case, which is a case number 2, where we have as you can see with that plus needle, we are trying to push inside the optic disc pit. The only thing is there may be damage to the optic disc. That is why we have to be very, very careful. Surgery usually is the people Dr. Rohan Chawla has done, but we know these are also doing fantastic. Now the question is what is to be, whether we should put gas or air. So we have seen that we are putting SF6, although in the many of the studies people have put SF6 and C3F8. Now this is the second case. As you can see, vision is 6/60, and after doing plugging, as you can see here, decreased, and you can see this is the plug, the square plug which is there, and with the OCT this resolution is very fast. Within 1 month you can see the maculatus has decreased, NST has decreased, and vision has dramatically improved within 1 month 12, and you can see that thing is closed. The pit has been closed by this thing. So this is the latest photograph of the first case, I would like to say, where PVD only was done, no stuffing, where resolution has occurred after a year. So only small amount is left. And this is the another case I would like to show, where after one surgery, the patient was 6/60 and pre-op. And after doing second surgery, again the fluid has not occurred. But after doing a repeat surgery, SF6 was injected. So it is a surprisingly, after 1 year, we have done the surgery, and patient vision has improved from 6/12 to 6/60 to 6/12. So in conclusion, in these cases, or the optic disc pit with maculopathy, treatment should be done when the vision is decreased and patient is complaining of. In this case, we have seen the two methods with the PPV injection only, and second is plugging. Plugging causes the early resolution, and visual outcome is very good. So the important message is we should be able to do cases which we are following should be done early after counseling the patient, because vitreoretinal surgery has improved. We have seen following many of the cases we are following, but they take long time. We have not seen any patient or resolution, only 1 or 2 patients which have resolved with the laser treatment only. So, any question, Parija? Thank you.
Thank you, sir. Thank you for the wonderful presentation. And I think it was a very illuminating talk about how to deal with these cases. Any comments from the panelists or the other speakers in the session? Okay, so in case there are no further comments or questions,
I
yes.
just wanted to ask one thing. How do we decide on the size of the scleral patch which we have to put? Do we need to put it slightly bigger than the size of the pit, or it should be almost equal? How do we?
We try to put little bit smaller, although it is not watertight. I don't know how it has worked, but it should be watertight. People have used the plug punctal plug of various sizes after calculating the optic disc pit size. So this is the case where try to put and there was a closure. It is very difficult. We should be able to assess how much size should be there by calculating depth.
Thank you.
Thank you, sir. So I think we'll go on to the next.
This is where I have shown PPB has also worked and where plugging is also worked. But plugging causes early resolution of the fluid. Another thing is people are against the gas, but we have seen 2-3 cases with gas in second surgery, the resolution has occurred. I don't know what is the mechanism. Thank you, Dr. Parija.
Thank you, sir. So now next I would like to invite Dr. Purna Chandra to speak on IRD role in electrophysiology. He has extensive experience in this. We welcome you, Dr. Purna, for this lecture, please.
So much for the opportunity. I'll start sharing my screen. So let me know once it's in the full screen mode. So how many slides seeing?
Yes, sir, the slides are visible.
It's in full screen mode, right?
Yes, sir.
So thank you so much. Good afternoon, everyone. So first, I would like to thank RP Center for this opportunity to come and share my experience on inherited retinal dystrophy and what electrophysiology has to do with these IRDs. I'll start with the basic introduction. So we know ERG is nothing but it's a mass response of a luminance stimulus to a retina. Whenever you stimulate the retina, there will be biochemical and ionic changes in the photoreceptor and RPE, which generates electrical potential, and this is recorded as electroretinogram. So coming to the origin, so the first negative deflection is the A wave, and this is from the photoreceptor, basically the outer retina, and followed by a B wave, which is predominantly from bipolar cells with some contribution from molar cells. Basically, this is from the inner retina. And along the ascending limb of the B wave, if you see, there are some fluctuation. These are called oscillatory potential, and these are from amacrine cells. So there are different types of ERG. One is full-field ERG, which is the response from the entire retina. The pattern ERG is predominantly from the posterior pole. In multifocal ERG, we check each and every point on the posterior pole. So this is how a typical full-field ERG printout looks like. This will have a dark adapted responses and also a light adapted responses. Dark adapted responses represent function of rod system, and cones light adapted represents predominantly a cone system. I won't go into the details of it because we don't have time. And this is how a pattern ERG looks like. The first B50 deflection, it represents macular function, followed by a negative deflection called N95, which represents function of ganglion cells. And this is the multifocal ERG where we check each and every point on the macula. So that's in brief about what's ERG and all. So to understand the role of IRDs and the role of electrophysiology in IRDs, I'll begin with a case example. Let me begin by taking the commonest inherited macular dystrophy, that is Stargardt disease, which usually happens because of mutation in a gene called ABCA4, which is located on the chromosome 1. Basically, it codes for the transport protein, and it functions to regenerate rhodopsin by accelerating removal of all trans retinaldehyde. So there is one grading system called Fishman grading, which is used to grade, which we still use for the clinical grading of Stargardt disease based on the fundus changes, OCT, and autofluorescence. So in the grade 1, there'll be very early atrophic changes. In the grade 2, there'll be, in addition to the macular atrophy, there'll be an extensive flex-like deposits, which is very classic of a Stargardt's. In Fishman grade 3, the atrophic lesion enlarges and this flex will start absorbing, but still limited to the posterior pole. In Fishman grade 4, so there'll be extensive resorption of this flex, which extends to mid-periphery also. Now, let's take this example. So this is a 23-year-old male with a vision of 6/60, had a homozygous mutation in ABCA4 gene. If you just look at the fundus photo and autofluorescence, it just looks like Fishman grade 3, have a higher grade Stargardt's. But if you look at the ERG, if you carefully observe here, both the dark adapted and light adapted responses are completely normal. So basically, this is indicating the disease is localized just to the macula and the rest of the retina is functionally intact. Coming to this second example, which is a 28-year-old male with a vision of 660, again had homozygous mutation in ABCA4 gene. And the clinically it did look like a Fishman grade 2 with atrophic macular changes and flex-like deposit. But if you look at ERG of this patient, same disease, same gene, the dark adapted responses are completely normal. If you look at the light adapted responses, there is some early cone dysfunction, which we call it as type 2 Stargardt's. So third case, 23-year-old male, again vision of 636, had a mutation in ABCA4 gene. Clinically, it looked like a Fishman grade 2 type of Stargardt's. But if you look at the ERG, so there is a gross reduction in both dark adapted and also light adapted responses, indicating severe rod cone system dysfunction. So this is the beauty of electrophysiology. If you just summarize these cases, all three are Stargardt's disease, all three have the same disease, but if you look at the functional component, all are different. So why this is important? Because the prognosis depends on the electrophysiological changes at presentation. For example, the first case, at presentation, if the fulfilled ERG is normal, the chances of progression is very less. As compared to the third case, on presentation itself, there is a severe rod cone system dysfunction, and these cases relatively progress faster. And this data becomes very important, especially when in the present era of gene therapy, where we like to try some vectors and all that. So coming to these two case example, these two patients came with blurred vision. Fundus both clinically appeared normal. The first patient had a vision of 636 and also had history of photophobia. Second patient just a blurred vision, 6/18 vision, no photophobia. If you look at the autofluorescence in the first patient, very subtle changes at the fovea. However, OCT did show subfoveal cavitation with a thinning of outer nuclear layer. So if you look at the ERG, the light adapted responses are, dark adapted responses are completely normal. If you look at the light adapted responses, it is undetectable. So basically the ERG is telling the entire cone system in this function, in this patient is non-functional, though the OCT is showing such a small cavitation. Let's see the second patient. The second patient, definitely there is an obvious atrophic changes which is picked up on autofluorescence, and OCT is showing foveal thinning with corresponding outer retinal loss. And just look at the fulfilled ERG. It is almost normal. So the first patient is a case of achromatopsia. So though the ERG looks bad, this patient has a mutation in a gene called GUCY2D, and this is a stationary cone dystrophy, and this patient is not going to progress much. The second patient is a case of Stargardt disease. If you see light adapted response, there is some amount of diminution in light adapted responses, and this patient had an ABCA4 mutation, and this patient may progress. So this is the beauty of ERG. Once we combine everything together, the whole clinical perspective changes. So, and this is one more case example. This patient came for routine checkup and an opinion for refractive surgery, no ocular complaints, has very high myopia in the range of -10 and -11. Vision was quite okay for this degree of myopia, and near vision was also fine. So this is the fundus photograph. There's an incomplete PVD, but grossly normal, nothing major changes in the fundus photograph. Just if you look at the OCT, it looked normal, but when it came to my opinion, in the subfoveal region, especially in the left eye, there is some kind of granularity which I saw, which can be seen in some myopic patient, but this was little suspicious for me. I asked my assistant to check the color vision, but his color vision was grossly abnormal in both the eyes. In the right eye, I was able to identify only the 3 plates, and left eye only the 4 plates. And this is the corresponding autofluorescence, not much there. This is the white field autofluorescence, just like any myopic cases. And just look at the pattern ERG in this patient. As compared to the normal, the P50 is grossly diminished. That means it is indicating a gross macular dysfunction, though the OCT is appearing normal. So this is the fulfilled ERG. The dark adapted responses are grossly reduced. The combined responses are relatively okay. The light adapted responses are almost undetectable. So again, so this is like the last case what I showed. Again, the multifocal ERG is showing grossly reduced responses. This is also a case of achromatopsia, which is a kind of stationary cone dystrophy. So these are the kind of defects what we usually see in a case of achromatopsia, subfoveal cavitations, what we see, but it can be absolutely normal also, as we saw in our case. And this cone dysfunction in an ERG can range from mild derangement to an undetectable response. So to summarize, if you look at these 3 OCT, these all look like a same spectrum of same disease with increasing severity. But the first case is a case of enhanced discone syndrome. If you look at the long and medium wavelength cone response, it's undetectable. But if you look at the ESCON response, there is an exaggerated responses, and this patient had a mutation in NR2E gene, which is known to cause enhanced ESCON syndrome, and ERG is almost conclusive in this. The second patient is a case of juvenile retinoschisis due to mutation in RS1 gene. If you look at the combined response, there's a classic electronegative ERG. If you look at this A wave, so the A wave is forming, the B wave, instead of going straight, it's not even reaching the baseline, it's getting terminated here itself. So this is the classic electronegative ERG. So the third patient, the fulfilled ERG was abnormal, but EOG was also undetectable. And this is a case of recessive BEST, what we call it as autosomal recessive bestrophinopathy. To conclude, I would like to say, I'm not able to cover, there's a lot to talk, many case example I can go on. But to conclude, I would like to say electrophysiology is an important tool to aid diagnosis. And I always remember the words which are taught to me by my mentor: do not fit electrophysiology into clinical diagnosis, fit clinical electrophysiology into clinical diagnosis into electrophysiology. Thank you so much.
Thank you, Dr. Purna. It was a wonderful talk, and I think the last message was very apt, that we should fit it into ophthalmology. And thank you for really illustrating so many wonderful cases and looking beyond what is actually visible to the naked eye. It was absolutely wonderful. Thank you so much. Any questions from the panelists or the other speakers?
Yeah,
No
very nice
questions?
talk, Pooja.
Okay.
Very nice talk, Pooja.
Thank you so much, ma'am. Hope I was not fast.
No, it was very nice. It was very nice. So thank you, Dr. Purnas, so much. So we'll go on to the next speaker now. Dr. Mayank Bansal will now talk on frontiers in retinal gene therapy. Where do we stand? He has extensive experience working on this, and it'll be interesting to hear what Dr. Mayank has to say on this. Dr. Mayank, please. Welcome back to RP Center.
Thank you for the opportunity, sir. It's a great feeling to be here and share the experience with gene therapy. So I'll basically divide the talk into gene editing, optogenetics, and gene augmentation therapy. And Dr. Purna has largely laid the grounds for most of it. And lastly, move towards sequencing and the importance there. So starting with gene editing. So this powerful tool, essentially CRISPR-Cas9, consists of this Cas9 protein, which along with a RNA, guide RNA, is able to identify areas of the DNA and bind to them. And thereby it causes a double-stranded break in the DNA. It's actually a part of a bacterial defense mechanism. And it's been harnessed to largely, give us gene editing potential. So this is a very high resolution microscopy, which actually shows how the Cas9 protein works. And here's the Cas9 actually causing a break in the DNA. This technology won the Nobel Prize and has been now purposed to be used in retinal dystrophies. And while it's a very potent kind of technique, it does have certain limitations. One is that some areas of the DNA where you don't want to have any kind of cut, there can be off-target effects as well. And also that not all areas of the DNA may have an editing that happens. So therefore, the technique has been further modified, wherein a deaminase domain is added to the Cas9 protein, and that is able to deaminate, for example, cytosine to a uracil, which is read as a thymidine, or an adenine base to inosine, which is read as a guanine. So these base editors are able to target point mutations. This technique has further been now modified into prime editing, wherein a reverse transcriptase domain is further added to it. And this allows us to target potentially all kinds of mutations, be it insertion deletions as well as point mutations. And now even further, wherein CRISPR is now utilized for RNA editing so that we don't make changes in genomic DNA. Now, coming particularly to retinal dystrophies, IRDs with mutation in large genes form excellent targets for using CRISPR-Cas9. And genes such as USH2A, which has actually 64 exons, is a large gene which cannot be packaged into a viral vector, would be an excellent target for using a gene editing tool. Similarly, dominant and gain of function mutations, wherein a gene augmentation therapy may not deliver sufficient quantity of the wild type gene, may be an excellent target for using Cas9 or CRISPR gene editing. Coming to where things actually stand, One of the most initial targets has been the CEP290 gene, the Brilliance clinical trial, where the product, which is called the EDIT 101, has been utilized to treat an aberrant splice site mutation, which causes a truncated protein in the CEP290 gene. And once you remove the intronic splice site mutation, a full-length protein has been formed. This has shown perhaps not as much of a change in the visual acuity, but definitely improvement in the... Pardon me. And yeah, so moving on to the next gene, which has been a target, has been the USH2A gene, wherein EDIT 102 has been utilized to remove more common mutation in the exon 13. And therefore, although you have a smaller, but a functional USH2A protein, which is functioning inside the eye. The third strategy has been to use the knockout and replace in the Rho gene, wherein two Cas9 proteins are actually utilized to remove the damaged DNA, the mutated DNA, and then replace with a correct or wild type copy of the gene. CRISPR is now also being utilized for developing VEGF, anti-VEGF therapy, wherein you're able to decrease the VEGF production using Cas9 to edit the VEGF gene inside the eye, and also to edit the C complement factor H gene, CFH gene, which is potentially causing a dry AMD. So this summarizes the techniques. And to overall summarize things, the challenge remains off-target effects and editing efficiency when it comes to CRISPR-Cas9. And therefore, the therapies need to be very tailor-made or precision medicine, wherein you're targeting particular mutations. And therefore, certain other therapies, such as the next one, the optogenetics, which are mutation agnostic, are perhaps gaining much more momentum. But then as CRISPR undergoes more modifications with base editing, prime editing, it's likely to see more and more utilization. Coming to optogenetics, optogenetics essentially utilizes a light-sensitive protein, the MCO or the opsin, multi-channel opsin, which once packaged into the viral vector is able to deliver the gene, the wild-type gene of the opsin, into the bipolar cells via an intravitreal injection. And one of the biggest advantages that it is mutation agnostic. So people who've been in phase 1 to a clinical trial have been shown to see 3 lines of improvement, as well as an improvement in the multiluminance mobility test. The last part of the gene therapies has been, of course, the one which is FDA approved, which is the Luxturna or the Voretti gene. And to briefly explain the mechanism around it, it essentially consists of the wild-type RPC-65 gene, which is packaged into the viral vector. Once injected into the subretinal space, it integrates into the RP, wherein it causes an expression of the RP65 protein, and therefore improved function of the retinal photoreceptors and RP. So the PERCEIVE study, which was a phase 3 study, actually showed that, to briefly summarize it, while there was not much of a change in the visual acuity, there's definitely an improvement in the luminance. And moving to other gene therapies which are being researched or which are showing promise is essentially the CHM gene for choroideremia, RPGR gene, which is for X-linked retinitis pigmentosa, which are both in phase 3. And again, a gene agnostic approach, which is for the NR2E gene, which once injected is able to cause a rod photoreceptor rescue. And although it's primarily been tried in Rho gene mutation patients in phase 1 or 2A. Other many gene therapies which are in early clinical trials, but these were the main few for retinitis pigmentosa. And gene therapy is now also being utilized as an anti-VEGF, wherein 2 major molecules are standing up. One is the RGX-314, which is similar to ranibizumab, and the aflibercept equivalent, which is the exobero gene. So now moving to the last part, which is the next generation sequencing. And there are so many genes which can potentially cause retinitis pigmentosa, retinal dystrophies. And the question often comes is that while there is cost, which is a factor, why sequence these patients? So whenever possible, it helps us know if any of the patients are eligible for clinical trials. It helps to do a genetic counseling to the patients, as well as inform them of prognosis. And The technology has also evolved significantly from Sanger sequencing to the NGS, where we're able to do a whole genome or a whole exome sequencing, or even a targeted sequencing. Most commonly, of course, uses the whole exome sequencing. And whenever the report comes out, we're looking at different variants, which could be classified as ranging from benign to pathogenic based on previous literature and the clinical findings of the patient. So without consuming too much time, I'll actually summarize the talk. So the take-home message would be that it's prudent to sequence whenever possible patients with IRDs. Gene augmentation and CRISPR gene editing therapies are especially relevant to preserve visual function, more suited for early intervention. And optogenetics is among the more promising therapies currently, more so for those with significant vision loss. Thank you. I'll end the talk now.
Thank you, Dr. Mayank. It was a wonderful talk, and it really shows where we are going into the future with this. And a lot of high-tech stuff is going to happen. And as more technology comes into this, we have a wonderful way forward in dealing with these complex diseases. Thank you so much. It was a wonderful talk. Any comments from the panel or from the speakers?
Right. Wonderful talk, Dr. Mayank. I have one question that you have explained about the subretinal injection of the RPE65 gene, but what about the CRISPR? How is it delivered to the target tissues?
So yeah, thanks, Devesh. At the moment, the EDIT 101 has been the only one which has actually gone into a clinical trial where it was delivered as a subretinal.
Okay, I hope that answers it. All right. So if there are no other questions, then thank you, Mayank. Thank you so much. And it's my privilege to invite Dr. Mona Bhende, who is an authority in this field, and she'll be talking about non-ICGA imaging for PCV. Welcome, ma'am. Welcome to our session.
Thank
We're
you
very
so
appreciative
much.
you are here.
Thank you so much. I'll just try sharing my screen and can you see my screen?
The screen is not started, ma'am.
Not start?
Yeah, it says started screen share. Yes, come now. It's come now. Yes.
Oh, yeah. 1 second. Yeah, so I've been given 7 minutes to talk on role of non-ICG imaging in PCV. So I'll probably use just a few case examples. We know PCV is it covers a very variable amount of clinical picture, believed to be a variant of neovascular AMD, can sometimes be detected on routine examination where you just see the quiescent stage with a few polyps. However, the active stage can present with just exudation, massive hemorrhage, or a combination of the two. And classically, we have been taught that there are certain clinical features which would tell us that we should do an ICGA because it's likely to be PCV, and these are the clinical findings, and also non-responsiveness to anti-VEGF therapy. And this was brought out in probably the first evidence-based guidelines for PCV way back in 2013 from the Asia Pacific group. And they also indicated these clinical findings as well as the typical ICG appearance, which diagnosed PCV. And we all know that in the old days, not so old days, we were doing PDT as first line of management. And the Everest trial used ICG as one of the major diagnostic criteria because we know Everest compared PDT with monotherapy. And we used the PDT spot based on the ICG lesion size. And there were certain typical features which were used to diagnose PCV and to guide management. And these were the typical features: the abnormal vascular network, which could be interconnecting channels or a branching vascular network, the presence of polyps, and certain features of the polyps as the stage of the angiogram progressed. And this is a set of 6 patients where you see the interconnecting channels here, the typical branching vascular network, just a branching vascular network with polyps at the borders. Here you can have a combination of leaking and inactive polyps, a chain of polyps with pigment epithelial detachment at the edges, and the newest feature of choroidal hyperpermeability. So we know that ICGA is desirable, but is it practical? It was probably practical in the era where we used to treat the patients, if at all, once in 3 months, and you can repeat it. But with monthly anti-VEGF therapy, it's highly impractical to do an ICG. So the search is always on to look for non-ICGA modalities. And this is a patient with a serosanguinous pigment epithelial detachment. The ICG shows the polypoidal network, leaking polyps within the PED. And if you do the cross-sectional OCT at different stages, you see the typical OCT features of the tall peaked PED, a thumb-like polyp, a double-layered sign, and also this complex or multilobular PED, which very well correlates with the ICG and the clinical findings. So it is definitely possible to diagnose PCV with OCT and clinical findings alone. And in this patient with the dense submacular hemorrhage, you see this kind of complex pigment epithelial detachment with ring-shaped structures below it, again indicating that this is polypoidal choroidal vasculopathy. And various authors from 2015 to 21 gave these structures various names: thumb-like projections, nodules, peak PEDs, ring-like lesions, multilobular notch PEDs, double-layered sign, and also defined pachychoroid. So all put together, the APOS PCV workshop decided to look at 9 major signs, both clinical and on OCT, and see which of them actually could diagnose PCV with certainty. And they found that there are 3 major criteria: the sub-RPE ring-like lesion that you see in figure B here, the unfast complex RPE elevation, here you have the neovascular complex and the PED, and the sharp peak PED on B scan, which were almost certain to be associated with PCV. In addition, certain minor criteria like the presence of an orange nodule, a complex or multilobular PED, the presence of a double-layered sign, and a thick choroid or dilated hallus layer were the minor criteria. Subretinal fluid and subretinal hemorrhage is no longer a criteria to diagnose polypoidal vasculopathy alone. Going one step further, when this group analyzed patients who were resistant to anti-VEGF, they looked at the non-ICGA based criteria and found that not only could you diagnose PCV, you could also use these criteria to calculate the PDT spot size, something that we had not been doing earlier. From there came this very nice infographic that you see in I 2022, which shows that PCV can be diagnosed without ICG at baseline. It can be diagnosed even if you have persistent SRF without an ICG, and you can do a PDT just looking at the OCT alone. So now that we've come to diagnosis, how do we confirm that the polyp has closed on OCT? There are a few major criteria: a densely hyperreflective appearance on OCT without a lumen, absence of fluid, absence of the ring, and few minor criteria which are almost similar to other CNVM responses. Going a step further, can we use OCT angiogram? Because we've been typically told that OCT angiogram only picks up the branching vascular network and not the polyps because of the differential in flow. But this study showed us that you could use cross-sectional OCT angiogram, which was much better than unfast OCTA, and compared very well with ICG features of PCV. So I'll just show you a few of my own case examples. This was a lady who had PCV diagnosed almost 15 years ago and had been relatively quiescent after multiple anti-VEGF injections. In between, she developed a pigment epithelial detachment in the papillomacular bundle. You see the PCV complex can be very well picked up here. And you see this ring-shaped pigment epithelial detachment. This suddenly reactivated. And now you look at the expanded image here, where you see this complex pigment epithelial detachment with these ring-shaped sub-RP structures, which are very typical for PCV. And here you see that this was reactivation, and then after treatment, the fluid has disappeared, but the PCV complex remains. And just last month, she came to me again. Vision was good, but then she had developed another lesion that was way out of the arcade, an area we thought previously could not be imaged on OCT. but we just shifted the focus to this area. There is a little bit of fluid under the macula here, but you see this large polypoidal lesion that is picked up well on the OCT angiogram, which is active. Initially, the patient underwent anti-VEGF injection where the fluid dried off, but you see the fluid around the extrafoveal polyp remained. Subsequently, she underwent laser photocoagulation. Now you see that the peripheral polyp is okay, but the fluid has reoccurred at the macula, and now she's due for her next injection next week. Similarly, we can pick up lesions in the asymptomatic fellow eye. This patient was undergoing treatment for active CNVM. You see the small little ring-like lesion in the papillomacular bundle. This is the regular serous OCT. This is not a swept source OCT. It picks up with careful segmentation, picks up this polyp and also gives you a hint that there may be something a little more than that. This patient underwent routine ICG angiogram, and you see actually there's a peripapillary network and a leaking polyp at the tip. This is a patient I started with swept source OCT angiogram. She was referred as atypical CSR. If you look carefully, there are these orangish nodules. A good OCT angiogram around the optic disc shows not only the branching vascular network, it also shows the polyps. And as I mentioned, the B scan with the flow signal can now be used. And this is the flow signal showing that there are polypoidal structures running under the pigment epithelial detachment, similar lesions just above the optic disc. Patient initially did well, but suddenly stopped responding. And you see this sub-RP ring-like structure that is there. There's some fibrin at the fovea, a very large pigment epithelial detachment. And this was her fundus appearance. Sometimes you still need to do ICG angiogram. We did an ICG at this point now. It shows the large polypoidal lesion. Part of it is highly active, but it also shows you that there are two RP rips within the PD, which is probably the reason suddenly for this large amount of fluid collection. So with all this, we are now seeing that we are shifting towards non-invasive imaging in PCV. ICGA is no longer the first line of investigation except in atypical cases. An emerging role of OCTA has been highlighted in the recent guidelines for PCV management that was presented and published in IGO 2022. Thank you very much for your patient listening. This is my first experience at an RPC meeting, and I am very thankful for inviting me.
Thank you, ma'am. It was a wonderful lecture and explaining about PCV in so much detail with such wonderful images. It was really enlightening. Any questions from the panel or other speakers would like to comment?
Yeah, I have a question, ma'am. So,
Yeah.
ma'am, these sub-RP lesions, the ring-like lesions, so do we also need to look at them for the resolution of PCV? Do they still persist even if the fluid has gone?
They can still persist. For one, they are signs of PCV being present. That's the first thing. They don't go away that easily, especially if they are very large, because we don't have any drugs that safely permeate. The patient I showed you, she had even had Pagenex, which is believed to be the best drug for sub-RP lesion. It doesn't go away, but just because it's there, we don't use it for a treatment guideline, but we do tell the patient it's there and it can come back anyway.
Thank you.
Thank you, ma'am. It was a pleasure to have you in this
Thank you so
meeting.
much. Thank you so much.
And hear you. So now I request Dr. Naresh Babu to please deliver his lecture on challenges in intraocular foreign body. And he has extensive experience on this, and I think it'll be very nice to hear him on this. Welcome, sir, to the RP Center meetings.
Sorry. Can you hear me, sir?
Yes, sir, we can hear you, sir.
Yeah. So once again, thanks RPC team and Dr. Shoria for this invitation. So, yeah. So as far as foreign body retrieval from the human eye is concerned, it goes back to almost 16th century. And interestingly, it was attributed to Fabricius' wife, actually. In fact, she was the one who prompted him, or she was the one who used the magnet to remove the foreign body in the eye way back in the 16th century. That was quite interesting. So probably the message is you should always listen to your wife, even if you're a great professional. So when it comes to the question of foreign body history is very, very important. We have to know about the patient in, toto. Times when we take the patients, especially in case of blast injuries and road traffic injuries, we come with patients come with inebriation of the alcohol, and we have to know the circumstances. So what was the nature of the foreign body and also its composition, because if it is inert, very rarely we can leave it also. And also the foreign body depends on the workplace, the residence, the occupation, and how it has happened and when it has happened. So all these things are very, very important because sometimes the history may be suspicious, but we may not be seeing the foreign body very obviously. But we have to look for a very elusive foreign body in such cases. In fact, we have missed a few foreign bodies and subsequently we have picked also. That's it. Okay. So as far as the clinical evolution is concerned, the clinical examination gives a lot of clue. In this, actually, we have come out with a patient with a chronic foreign body where we can see the cirrhotic changes. And many times in cirrhotic changes, the affected pupil will be larger in size. We attribute that to dilatation. So dilated pupil, in fact, told by the patient itself is a clue for us to know that there is a cirrhotic foreign body inside the eye. And before taking the eye for surgery, we have to completely classify the injury based on the open globe injury and the closed globe injury classification, because that will help us to prognosticate the patient. And any subtle things on the cornea and the sclera should be looked for. In this case, there is just a subconjunctival hemorrhage. We cannot see a very obvious tear in the sclera, but still when we went inside, we could see an intraocular foreign body. So if somebody who is not very particular about seeing the foreign body dilating the fundus, this could have been missed. So we have to be very careful in localizing the foreign body. And we have to prognosticate the injured eye and to the patient based on this ocular trauma scale. So to some extent, it will, bring the patient to a sort of reality, like what his vision is going to be, because most of these trauma cases they have a very high expectation regarding the visual outcome. So to localize the foreign body, there are various things. The first and the best is ophthalmoscopy. Before the media becomes hazy, we have to dilate, and the direct visualization of the foreign body is very important. I'll show in the next video why it is important. And the X-ray PA view for all medical legal purposes is mandatory. Ultrasound B scan with the gentle usage of the probe can tell us about the collateral damage associated with the intraocular foreign bodies. CT scan for all the metallic foreign bodies. Once we rule out the metal, and in case we are not able to see the foreign body, then we can go for MRI. But rule out metal before we take the patient for MRI. So for medical legal aspects, we have to look for, do the investigation. Missing an intraocular foreign body is professional liability. And we have got few judgments which has gone against for missing the foreign body. So is CT scan indispensable? I'll say sometimes if the facility is available, yes, we have to make use of. This is a case which was very recently operated by me, a patient for CT scan. So this was the picture actually. So the foreign body was deep inside the optic nerve head, which was missed by me before taking the case for the surgery. So sometimes X-ray may be deceiving and the ultrasound is also deceiving. In such cases, to go for a CT scan is mandatory so that we can localize the foreign body accurately. As far as the open globe injury with or without foreign body will have 3 windows, basically the acute window, subacute, and the chronic window. Usually in case of chronic windows, we'll be managing the sequelae or complications like chronic RD or cirrhotic changes. But first 24 hours is important. Even if we are not removing the foreign body, it is better to restore the integrity of the eyeball, and we have to take measures to avoid the, the infection. So there are few objectives while managing foreign body or any open globe injury for that matter is to basically establish the integrity. Then we have to prevent the infection, remove the foreign body. Then we have to maintain a very clear media and manage the RD if it is associated. And IOP control is also important. And last but not the least is the sympathetic ophthalmia, which might develop in the fellow eye. So the surgical consideration depends on various factors depending upon the mode of the injury and its nature and the localization, and also the presence of infection. As far as all, foreign body, if it is reactive, all foreign body has to be removed. But in case if it is an inert foreign body, if it is going to cause any mechanical damage because of the movement, it can be removed. Otherwise, sometimes rarely it can be left inside. So this is the recommendation which is given. But it says except for the intralenticular foreign body without any lens or without any electrophysiological changes, that is the only foreign body which can be removed. Otherwise, every other foreign body inside the eye literally has to be removed at some point of time. And the most important thing is in case of the chronic foreign bodies, where they come with ocular cirrhosis, when we remove the foreign body, there is improvement in the ERG as well as the visual changes after the removal of the foreign body. So, except if even if the ERG is flat, we can take the patient for intraocular foreign body removal, provided the EOG is normal. In the presence of both flat ERG and very low Ardens ratio, then that is the condition where we can leave the foreign body because the prognosis may not be that good. So there are two types of removal, either it's the immediate or the late removal. The basic advantage is a single procedure with the decreased risk of endophthalmitis. But the other side is like if you remove it immediately, the integrity of the laceration may not be that good. It can give way, and sometimes the cornea is bad. We may need keratoprosthesis, and there will be associated anti-segment pathology also. In case of delayed foreign body, we'll have definitely a better integrity of the repaired laceration. Even the edema or other things in the anterior chamber can resolve, that can give us a better visualization. With the corneas, it's a two procedure, so the rehabilitation takes a longer time, and in fact, there is a very high chance of both endophthalmitis as well as the PVR changes. When it comes to the question of no PL, NPL is not at all a contraindication, especially in case of open globe injury as well as in the foreign body. So any NPL, after explaining the patient, we can operate, and we have also seen patients turning to even 5/60 after surgery. There are basically three routes, but we will not be discussing with all the other routes. Most of the foreign body is retrieved by pars plana route only. But before we go for the removal of the foreign body, we have to know about the foreign body, and we have to choose the appropriate, instrument for retrieving it. Most of the small foreign body, which are magnetic and metallic and magnetic, can be retrieved with the help of this is intraocular rare earth magnets. Then we can use the large forceps for the large foreign body. It can be diamond coated forceps. The recent one of Dr. Manish Bapa is a wonderful thing. I found this very useful for two things, where the surface is very smooth, like in case of this ball-bearing walrus, as well as the irregular large foreign bodies. So this is a wonderful tool. Actually, only thing is we have to make a large trapdoor scleral incision to remove the foreign bodies in these cases. And if we have this, it's well and good. This is an electromagnet which produces a wonderful magnetic field outside the eyeball, so that when we bring the foreign body to the sclera, when we use this removes most of the foreign body with ease. So we'll just go to some of the foreign bodies which we have retrieved and the challenges in them. I'll just skip some of them. So this is a case of intraocular foreign body, or rather injury with thorn. The challenge in removing the thorn foreign body is when we remove the thorn, there will be an outer cap over the thorn that is usually left inside the eyeball when we are retrieving through the scleral route. So in this we can see this is the thorn which is inserted inside, and in fact this eye was made aphakic already during the time of the scleral wound suturing. So we thought that we'll remove it through the scleral scleral tunnel route. So after localizing and after doing a complete vitrectomy, we made a larger sclerostomy. Then the sutures were removed. As I told, there is still some amount of, when we are pulling it out, some amount of the thorns material were there inside, then it was removed through the transpupillary route, and the rest was cleared. This was another case. Sometimes with the small foreign bodies which we cannot localize, we go for a fluid air exchange so that we get a better field of view. We have done the depression, scleral depression, and we could see the foreign body in the past plana almost at 6 o'clock meridian, quite anterior to the ora serrata. So it was depressed, and then with the help of the forceps, it was removed because it was in such a complicated location. So what we have done is we have made a sclerotomy at around 12 o'clock so that we can go directly into the 6 o'clock meridian with the help of a rare earth magnet. As I told, small foreign bodies can be easily managed with the rare earth magnets. So you can see the foreign body getting attached to the rare earth magnet, intraocular magnet, and then it was retrieved. So sometimes when we see the foreign bodies are quite large, again, we have to remove them through this. This is a case with some amount of infection as well as the vitreous hemorrhage with the deimmunized blood. But when we went inside, to our surprise, you can see the foreign body was just standing over the optic disc like a tower actually. And it was quite large enough also. While trying to remove, there was some detachment which was managed. In this case, again, after pulling the foreign body gently from the optic nerve head, as it was large, usually we go for a transpupillary route. So we sacrifice the lens, and then the foreign body was removed through the pupillary route. The only mistake we have done is the triplanar incision of the sclera. Sometimes it makes our life difficult. So we can go for a single plane incision that can help us. So as I said, localization is very important. This is another case.
Excuse me, sir. Can you kindly
inside.
summarize now, sir? Because
After the vitrectomy, a complete search was done. Then I couldn't find the foreign body. Then I thought we'll just go extraocular. 2 muscles were bridled. But fortunately, I was lucky. So I was just searching with the help of a magnet in that quadrant outside the sclera. And to my luck, I think the foreign body was just, it has gone inside and it has come out through the course. So sometimes we are lucky, but many a times we may not get this. So when I was searching with the foreign body, I could feel something hitting. So we can see the foreign body which has come out of the sclera. And since the retinal wound was in the periphery, this eye could be saved. And many a times, I'll just skip this. It is very, deceiving actually. As I told, this was by a 57-year-old woodcutter. In all these cases,
Babu, could you
open globe injury, when we remove the exudates, usually they'll be having a small wooden foreign body. So we can find there is a small corneal wound which was sutured. Then I went and did the core vitrectomy. After that, we washed the exudates.
Excuse me, sir. So we are running short of
Sir, we are running short of time. Can you,
at the site of the
sir,
injury,
Dr. Babu?
we could find the small wooden foreign body. This is the foreign body which was there, which was then gently removed with the help of
Voice
a
is not going.
23-gauge instrument. The reason for showing this is if we don't give attention to this foreign body, in spite of doing the core vitrectomy, these patients will never have the resolution of the infection. So especially in organic material, these small foreign bodies we have seen very frequently at the site of impaction. So history as well as precise localization is important, but these things cannot be seen with CT or if facility is available, MRI can be useful. So this is the case of the fundus photo of the same patient who had a 6-9 at the end of 1 week. So as far as prophylactic buckle is concerned, it may be useful, but nowadays most of us, we don't use. And retinopexy, yes, if there is any breaks, it can be done. And the most important thing is counseling. It has to be done in groups because every time one new relative will come and will be asking a lot of questions. So we usually take all the stakeholders and do the counseling. And sorry for using the word brutal, because many a times their expectation is very high. So we have to give the what do you call very realistic outcome of that particular case. And the need for multiple surgery in any case of trauma has to be explained, and we have to be very frank about the prognosis, and the risk of phthisis should definitely be explained, especially in case of women. And the prognosis in all these foreign body, as I said, depends on the foreign body's impaction site. It may be small in size, but if it is over the macula, then the outcome is bad. And non-magnetic foreign body, it is difficult to retrieve, but many times they are fine. And in case of a failed surgery, the prognosis is bad, and associated ocular damage can always can lead to a poor prognosis. The size and composition of these foreign bodies matter. If it is an inert foreign body, and especially glass where we cannot retrieve, we can just keep it in the periphery, bury it and leave it. Most often the prognosis is good in such cases, rather than retrieving, because we may be tearing the retina, and because it might fall multiple times, then we need a larger what do you call opening, all those things. But any reactive foreign body like copper or iron has to be removed. And in such cases, usually because of the cirrhotic changes as well as the acute inflow, endophthalmitis like picture in copper, the prognosis is usually poor. So finally, a few take-home points, which include that we have to go for a thorough history as well as a meticulous examination. Any subtle sign should be given importance. A gentle B scan should be done so that we will not expel any of the contents. CT scan in all cases of OGI, if it is available, at least it is recommended, so that we have a very precise localization. And we should always have, in case of history is conclusive, in such cases, we should have a very high index of suspicion, and we have to rule out any elusive foreign body which may be situated in the places which cannot be seen or localized that easily. And all foreign bodies, we can go for early vitrectomy with the removal. And as I said, the prognosis mainly depends on the site, size, chemical composition, as well as the ocular comorbidities. Once again, thanks for the opportunity, and thank you very much.
Thank you, Dr. Babu, for the wonderful lecture and prescribing, so many different ways to deal with the techniques regarding intraocular foreign body. Thank you so much. Next, I'd like to invite Dr. Parag Shah to speak on oxygen and aggressive ROP. Dr. Parag has an extensive experience in speaking about ROP, and he deals with a lot of these cases, and it would be interesting to hear him about this. Welcome, Dr. Parag, and looking forward to hearing about this.
Thank you, Parijat, and thank you, RPC. Congratulations on the 50th Foundation Day. Shaurya, thanks for the invitation, and really nice to have this on Zoom, because it just makes such a lot of economic and environmental sense even in this age. So thank you for doing this. So I'll be talking on oxygen and aggressive ROP. So what are the reactions between oxygen and ROP? Well, these are the reactions which I get whenever I'm from the audience, that there is nothing new in this. And people still say, you're still stuck on oxygen. People have moved on, and they are do some cutting edge technique, technology. People are finding, biomarkers in tears and urine, and you're still stuck to the same old story. But like what Margaret Thatcher had once said, that of course it's the same old story. Truth usually is the same old story. And why is it important, ROP? Because we still haven't crossed the hump, which was crossed so nicely in the 1950s by the ophthalmologists in the developed world. They crossed the hump of the first epidemic, but unfortunately it has come back, and we are still lingering around it. And it's just because of the lack of coordination between us, the ophthalmologists, and the neonatologists. So this is the tragedy of easy problem. This is the word I have taken from this speaker, Prajwal Sirium. And the problem is, the easy problems have solutions which can be economically feasible, technically effective, and logistically scalable. And easy problems are everywhere. Now in cataract blindness, we have the DBCA, so many camps going on. So we are really tackling in such a small 5-minute operation can, restore blindness. Diarrheal diseases, simple hand wash in filtering the water can eliminate this. Childhood vaccination, vitamin A deficiency, which was such a big problem way back in 1960s. The Keratomalaysia, so ophthalmologists and pediatricians really did an excellent job in eliminating in vitamin A deficiency. And of course, there are more diseases in this list, and I've just added ROP, but unfortunately, ROP is still lingering, and it is because of lack of coordination between the ophthalmologists and neonatologists. And this is the difference between the developed world, where it is quite coordinated. ROP is still quite quiet, but it is like a wildfire happening in countries, especially in rural India, where there is not much coordination between the ophthalmologists and neonatologists. Just a quick down memory lane. In the 1940s and 50s, there was appearance of the disease called retrodental fibroplasia. Now, why did it appear at that time? It's because the oxygen chambers were just introduced way back then, and all the preterm babies were given 100% oxygen, and they saw developing this disease. So the first epidemic happened between 1943 and 53. Almost 77,000 children went blind. Stevie Wonder, who's a great singer, also was part of this epidemic. And it was published in the cooperative study of RFL by 1956 by Kinsey, and they recommended the oxygen concentration should be less than 40%. And when they did that, it was a happy ending. So what is going wrong? What is the current confusion right now? Well, if you see that in the 1950s and 60s, oxygen was just measured in concentration, but now we have the pulse oximeter, which are developed in 1972, and there's a saturation, and both seem to be, sound quite similar. Both are in percentage, but actually both are quite different. So Kinsey and all in this study, they said that for all practical purposes, there is no concentration of oxygen in excess of air that is not associated with developing ROP or RFL. So anything more than 21% of concentration has a risk of developing ROP. Second thing is that they recommended the concentration of oxygen used in the care of preterm infants should not exceed 40%. And that time it was given widespread publicity in the various medical and lay agencies. And they recommended that the concentration should be as low. The concentration should be as low as possible. But the problem is now that we've forgotten about the concentration, because now we catch the saturation. But the saturation, the truth is, this is the oxygen dissociation curve, that how much of a concentration of oxygen you give to a child, the saturation is never going to go beyond 100%. But the partial oxygen concentration of oxygen in the artery, the arterial gas, will go much beyond 100 also. And you can see if a normal infant is getting 80% oxygen, it will go to almost 322 millimeter of mercury, which is extremely toxic for the child. So why was it called retrodental fibrosis at that time? Because the clinicians were unaware of the retinal changes which are happening before the white mass, which is just the stage 5 ROP, because there was lack of indirect ophthalmoscopy, and of course fundus imaging also was absent. However, Arnold Patz in 1968, he had mentioned that severe vasoconstriction of the preterm retina as a specific response to hypoxia is possible. And they show that exposure to 80% of oxygen in severe preterm babies led to a vasoconstriction. And 4 babies ultimately developed retrodental fibroplasia after developing the dilatation and tortuosity. So during that time, and this is how he showed the diagram in that thing of vasoconstriction, which is happening after giving high concentration of oxygen. And even 1953, they tried to, this is all before the ICROP classification. At that time, there was no ICROP. This was during the first epidemic of ROP, and they tried to classify ROP. And here also, they put the first phase of dilatation and tortuosity, which I'll show you in the subsequent slide how we see right now also. So Arnold Patz, he gave this picture in 1968 that this is a stage of retrodental fibroplasia, and attention was called because funnel over mouth oxygen was given. And this is what we published in 1912 in one of our NICU. This is the same thing was given, funnel over the mouth. And these are the fundus pictures which we see. That the difference is this will go for retrodental fibroplasia stage 5. During 1950s, there was no means to document it, but now we can document this, and this is what is happening. And we also saw that actually 35 babies, the vascularization from zone 2 retracted to zone 1, and 4 babies even from zone 3 became zone 1 because of the high oxygenation. And we just changed the simple from a funnel to the hood, which is the crude way of blending oxygen. The AROP cases dropped from 30% to 0% in 1 year's time. And not in a single NICU, we have seen this in multiple NICUs in a telescreening program in 2 time zones, that the type 2 ROP from 60% dropped to 17%, and the treatment-related ROP from 8 it's almost 17% to 5%, just by having these CME programs for the neonatal staff of how to regulate oxygen, not to give the unblended oxygen. So this is the 1953 image. You can see how it is shown here. And this is the 2021 ICROP3 image, which is one of our images was published. And you can see the similarity between the two images, not only in the looks of it, but if you see here the description also, the early neoaspiration, especially in the extreme periphery of the visible retina, was present. And now we know that aggressive ROP, it's beyond the posterior retina, the neoaspiration is present. So it is nothing but the mummy returns. It's coming back from the 1950s. The same disease is coming back. Only thing we are able to document it much earlier now. And this is what we have published recently, that after 70 years, it is all coming back. And this is with Alistair Field and Graham Quinn, who are one of the two pillars of the ICROP3 classification, and Brian Darlow and Neil Marlowe, who are leading neonatologists in UK and New Zealand. They all believe that, and we have shown here that there's actually a regression of the retinal vessels is happening after oxygenation in our babies. And this is nothing but what was happening in the 1950s. So ICROP is everything new. These nine modification, unfortunately not. The aggressive posterior ROP changing to aggressive ROP is actually from the dark ages. So when do pediatricians in India use oxygen blenders? This is how an oxygen blender looks when they are on CPAP machines or on ventilators, which comes as a part of it. However, is there an alternative or not? So we have come out with this. I mean, not that we have come out with, but there are these low flow oxygen meters, which are much cheaper, 1/10 the cost. And we are doing a study which is funded by the VRSI in 11 government SNCUs, and the results will be out too soon, because these are you can see here, these are the extremely low flow from 0.1 going to 2 milliliters, and it does not require blenders. You can give pure oxygen. It does not require a central oxygen line or air also, and it can be attached to the cylinders also directly. So this is the protocol of oxygen which has been given by a neonatologist. The target saturation of the neonate should be between 90 to 95. Use oxygen only when it goes below 90%. Use low flow oxygen meters whenever possible. Use the lowest flow required to maintain a target saturation. And when saturation is above 95, reduce the oxygen flow and try to wean off as soon as possible. So in conclusion, eyes don't see what the mind doesn't know. We know that. But in this case, the mind knows, but the eyes are not willing to see. And the blame game, who's responsible for this between the neonatologist and the ophthalmologist. And unfortunately, a generation of babies are getting blind in the rural NICUs of India because of this discoordination. So if ophthalmologists and neonatologists work hand in hand, not only the risk of the babies will reduce, but even the cost also will reduce dramatically. So thank you very much.
Thank you, Dr. Parag, for the wonderful lecture and giving us a relook on oxygen with some historical perspective as well, which was really very interesting. So thank you so much. So in the interest of time, I think we won't take any questions right now. We'll just move on to the next speaker. So thank you so much, Dr. Parag, for coming to this meeting and sharing.
Thank you.
Thank you so much. So I now welcome Dr. Tapas Padhi to come and share his views on a combined strategy to address retroretinal membrane in stage 5 ROP. He's a prolific surgeon, and we look forward to hearing from him. Welcome, Dr. Tapas.
Yeah. Thank you, Dr. Parijat, and thanks to the entire RPC team for the invitation. And I express my respect for the seniors and the many colleagues present here. Can you see my slides?
It's again gone away now. It was there earlier, but it's gone away now.
1 minute, let me share again.
It's coming now. It's coming now. Just make it full screen here. Slideshow. Yes, that's okay.
So what I'm going to discuss is on a retrolental membrane that is common between many advanced pediatric retinal diseases, including retinopathy of prematurity, FEVR, PFV. So I would focus on the retrolental membrane in case of advanced retinopathy of prematurity. Now, we know that the stage 5 surgery is a daunting task, and the key steps include proper preoperative evaluation, lancectomy, handling of the retrolental membrane, the retinal folds, unveiling the peripheral trough, address the major tractional forces, and handling the central stalk. The complications, if any, are usually less forgiving. Before I acknowledge the article from Shankar Netralaya, which clearly tells us that the peripheral avascular retina is doesn't have any subretinal space, and it resists stretching or detachment. As a result, we get a configuration of the stage 5 ROP like this, where the retina is pulled anteriorly and it gets attached with the hyaloid stroke and the vitreous condensation around. And finally, the retinal fold sticks to the retrolental membrane anteriorly, which again gets stuck to the posterior lens capsule. The retrolental membrane here, while it is attached attached to the underlying retina, it is also attached to the ciliary body region and sometimes the pooled anterior retina. The main aim of dissecting this retrolental membrane is to safely push the retina back and relieve the major stalks and open the peripheral retinal trough. The retrolental membrane, that is the point of concern here, differ in many ways from the membranes that is seen in cases of diabetic retinopathy. The histopathological slide shown here shows that it is predominantly collagenous with very minimal cellular structure there. The advantage of this is that the moment you cut and dissect it, it nicely gets separated from the underlying tissue. Traditionally, this retrolental membrane is approached in two ways. One is outside in technique, where the membrane can be separated from the ciliary body region and slowly dissected over the retina and brought to the center. So this gives you the best exposure and the best outcome. But unfortunately, many times one can have a cyclodialysis or retinal dialysis, as you can see here, the sclerine we can see. So that is one of the major disadvantages here. Sometimes you can have a torrential bleeding. The second technique is the inside out, where while doing dissection, one starts with the center of the retrolental membrane and goes to the periphery. Here, it is a bit safer than the outside in technique. But what happens when we keep on dissecting the peripheral trough, the retina falls back outside and the peripheral trough collapses. So the exposure of the underlying retina is comparatively less or poor compared to the outside in technique. As we can see here, there are lots of tissue here, though this is a case of stage 5 ROP post-surgery, though the part of the retina is attached, there is still lots of tissue left behind at the periphery. So we propose a combined mechanism where we start at the center, making an opening at the center in the less fibrotic area, then a radial extension and dissection from the underlying tissue, and circumferential extension and dissection just sort of ciliary processes. So this has two advantages. One is we go from the center to the periphery, and periphery we leave behind a strip of tissue so that there is no excessive pull and the risk of cyclodialysis and retinal detachment decreases. And while the dissection from the periphery towards the center gives us adequate exposure to the peripheral trough. So this is a surgical video where the translimbal incisions are made. Usually the translimbal incisions appear to be safer than the pars plicata entry, where there can be a risk of injuring the retina. Once the three scleral ports are made, the AC is formed with the viscoelastics. The lens is eaten away with the cutter. Finally, the capsule which is there is gently removed after injecting viscoelastics. This gives us adequate exposure to the retrolental membrane behind. So the retrolental membrane behind under transillumination can show up the underlying retina, and a place is chosen at the center which is least fibrotic. And as you can see here, radial extensions can be made on either side, whichever as per the convenience. And from the center, I'm coming to the periphery. And at the periphery, while just short of the ciliary processes, I go again circumferentially, as you can see here now, so that the circumferential, the traction on the ciliary body and retina is minimized. It is akin to truncation of the cone that we do during vitrectomy. Then once I have cut the circumferentially, I go back and release the adhesion between the retrolental membrane and the underlying retina. Now the curved seizure is a boon here, because while the sharp edge helps in cutting, the blunt edge helps in dissection and just separation of the tissue from the underlying retina. So usually, again, the dreaded fear is a retinal break in addition to cyclodialysis and bleeding. So excessive uncontrolled bleeding can jeopardize the surgery. So the moment any bleeding happens, so it's wise to raise the infusion bottle or infusion pressure or diathermize, or the one thing that helps me is putting some amount of Helan, injecting some amount of Helan and doing the dissection under Helan, so that one can see the blood vessels adequately. There is no unnecessarily constriction of the blood vessels. It also helps in separating the membranes or fibrovascular proliferation from the retina. Towards the end of the surgery, some amount of Helan can be left behind, so that there is no undue hypotony and undue movement of the retina and prolapse of the retina anteriorly, or there is no undue bleeding. So even while closing the port, it's very important to make sure that the ports are closed airtight. And while there are many good technique and reports that show sutureless closure of the wound, I usually prefer to put a suture and closing the ports with 10-0 vicryl has the advantage of the self-observable nature of the sutures. One need not remove it again. And as you hear, I'm just opening up the peripheral trough. You can see the central part of the retina, which was pulled anteriorly, is slowly going back, and the peripheral trough is opening. Residue is visualized here. The whatever residual tissue that could be removed safely, that is being removed. And this is now with keeping some amount of Helan and suturing the ports, especially the last port when the infusion cannula comes, helps in preventing unnecessary bleeding. So I go to, this is the case that we saw for 5 months. We can see that part of the retina is getting attached. Rest of the retina is less bullous. Now removal of the central stalk or highlight is very, very crucial and difficult. If it doesn't come easily, it's I feel that I leave them up for the second stage surgery later on, when the major part of the retina attaches and the membrane edges separate, and that can be addressed later. This is again 9 months. Slowly you can see that a lot of the retina is getting attached, and I expect that later on, when further attachment happens, one can go inside. This is another case where
can you kindly conclude in the interest of time?
Yeah. So I go to this is the technique. Sometimes the small people the iris retractor can be used to have a better access. So I go to the last slide. You can see the retina starts touching, and it takes lots of time, years together, before you conclude. So in conclusion, I describe a technique where combined inside out and outside in technique to address the littoral membrane that gives an advantage of opening up the peripheral trough better, at the same time reducing the risk of cyclodialysis or retinal dialysis. Thank you so much for the
Thank you,
kind
Dr. Tapas.
listening
It
and the
was
invitation.
wonderful to see those surgical videos and managing such a complex situation with your technique. It was really very nice. Thank you so much. And so we'll be
Thank you
not
very
taking any questions right now in the interest of time. So thank you so much for sharing your views on this subject. Thank you so much. So next, I would like to invite Dr. Brigadier S.K. Mishra to kindly share his views on brolucizumab and DME, the RR experience. Dr. Mishra is very experienced in this field, and we welcome you, sir, and we look forward to hearing from you on this.
Thank you. Thank you so much. Thank you, sir. Just share my slide, please. Just a second. Is my slide visible?
It's not visible, sir, yet.
Now?
It's coming now, sir. Yes.
Okay. Thank you so much, Professor
It's not full
Parijat.
screen as yet. It's not full screen as yet.
1 second. Now it's
Yeah,
done?
thank you. Yes.
Yeah. So thank you so much, Professor Parijat, sir, for inviting me on this prestigious meet. Being an alumnus of this prestigious institute, it's my honor to present my experience, the experience of my institution on brolucizumab in macular edema. So we all know that we have done a RCT. Well, it's a presentation of RCT on brolucizumab in DME. And we will also see the further application of brolucizumab in our practice. So we know that 2 doses of ranibizumab was approved by FDA. That is 0.3 in DME and 0.5 in CNVM. And in Kestrel study also, the outcome was studied in both the groups. And the hypothesis is that intravitreal administration of biological molecule provides easy access in the pre-retinal space, and it's which is a major target for the diabetic retinopathy. So we enrolled 2 groups, one group receiving 6 mg of brolucizumab and other receiving 3.6 mg of brolucizumab. It was the ethical clearance was taken, and it was registered with the CTRI. In inclusion criteria, we had both the type 1 and type 2 group of diabetic mellitus with HbA1c of less than 10. Treatment naive cases were taken in all these studies. A presence of NPDR with center involving diabetic macular edema, BCVA of less than 0.1 on logMAR units, and the CMT of more than 300 micron. And exclusion, any evidence of proliferative diabetic retinopathy or any intravitreal injection or a laser treatment done for were excluded out of this study. So what we differed from the other studies that we did right from the beginning of PRN therapy. A 4-weekly interval was chosen from week 0 to till 28 weeks. And BCVA measurement was done using logMAR units, and a central macular thickness was measured on each visit. The safety concern was given a priority. That patient was monitored at day 1, day 7, and day 28 of giving the brolucizumab. Any presence of the retreatment criteria was that any presence of intraretinal fluid on SD-OCT, presence of subretinal fluid on SD-OCT, reduction of BCVA of 0.1 from the last injection, and increase of central macular thickness of more than 350 micron in absence of SRF and IRF. So the ocular adverse effect were graded from 0 to 4, And 4 was what is more important, that with the evidence of hypopion, synechiae formation, vitritis of more than grade 2. So this was given a more importance and were recorded. So if we see the results, both the groups were equally matched as far as the age and other criteria were concerned. If you see this, the box and whisker plots showing a vision change in the group receiving 6 milligram of brolizumab from the first, that is 0 week, that is from 0.74 to week 28 at 0.12. Similarly, in the other group also, this is on the group which received 3.6 milligram of brolizumab. The vision, again, there was a change and improvement of vision from 0.735 on week 1 to 0.25 on week 28. This is the comparison of BCVA in both the groups. It was again in the 6 milligram group, the BCVA improved from 0.74 to 0.26. This is on the chart, and this is on the group received 3.6 milligram, again improved from 0.74 to 0.27. So the CMT changes in the 6 milligram group, it reduced from 371 to 273 at 28 weeks. And again, in the 3.6 milligram, it reduced similarly. The number of injection in both the groups, the group 6 milligram received 119 and the 3.6 milligram received 112 injections. This is the week-wide distribution of the number of injections received. Ocular side effects in the 6 milligram group, grade 3 side effects were seen in 4 and grade 4 in 1. It was managed with the PST of 40 milligram, and the preoperative BCVA, which reduced because of the inflammation, reversed back to the stage that is week 1, and the final BCVA was 0.6. This patient received more injection, one more brolizumab injection without any adverse reaction. In the 3.6 milligram group, grade 3 reaction were noted in 3 patients and grade 4 in 1. Again, similarly, the patient recovered and the final BCVA was 0.1. So here one thing is important to tell, that in brolizumab, it is not necessarily that you see the side effect in the first post-operative day. It can happen with in the 3rd week or the 4th week, and also it can happen in the second injection, not necessarily happen in the first, but in the second injection. So one has to be, always careful and screen these patients, especially on the day 1, dilate the patient, see the retina carefully, and look for any subtle signs of any inflammation. So the take-home message is that brolizumab is an effective treatment in the center-involving DME, can be used as a lower dose of 3.6 milligram. A PRN basis can be employed right from the beginning. Patient require 3 injections in 28 weeks on an average, and adverse events are manageable and pose no contraindication to reuse of brolizumab. So this was our study, which was published in the Neovascular AMD on brolizumab, with compared with the aflibercept group. And we've seen the number of injections required, or we studied this patient, over now more than 100 weeks, and we've seen the number of injections in the brolizumab is much lower, and the drying effect of brolizumab is much more superior to aflibercept. So the current status that we have used more than 2,300 injections, and we have seen that none of the eye was lost to any inflammation. Though we did see around 6 cases of inflammation, but were all managed either with topical or oral steroids. Another indication that myopic CNVM, normally it's a type 2 CNVM. Conventional is to use the 3 loading doses followed by PRN. Now there's a consensus which is building up of going for PRN right from the beginning. Normally, bevacizumab and ranibizumab is used in these cases, but we have started giving brolizumab, and it has shown promising results. This is a case, myopic CNVM. This is a 32-year-old lady with a BCVA of 6/9, received brolizumab, and at 8 weeks, the macula was dry and patient was asymptomatic. At 12 weeks, received the second dosage, and the metamorphopsia responded very well. And at 28 weeks, the patient has a vision of 6/9 and with a completely dry macula. Other novel application of brolucizumab we have used in the case of von Hippel-Lindau disease. Large angiomas usually require anti-VEGF prior to excision, and normally we use ranibizumab in these cases, but we used brolucizumab and went for the. If you see this, there was hardly any bleeding from these angiomas, and the patient responded very well to the treatment. Also, in cases of subretinal bleed, that is a subfoveal bleed, we have used this brolucizumab subretinal, and this is a patient, one-eyed patient. The other eye was lost to again CNVM. This eye had a you can see an old bleed and followed by a fresh bleed, and this was treated with intravitreal TPN and brolucizumab. So the patient recovered a vision of 636. So our take-home message is that brolucizumab is an effective, very effective form of treatment. And initially, what was the concern of inflammation and vasculitis? We have not seen any, and it is a very effective and the highest, I would say, the drying effect of this drug is the highest of all the anti-VEGFs. Thank you.
Thank you, sir. It was a wonderful presentation, and thank you for sharing such a vast experience in dealing with this disease with brolucizumab. So I think if there is any questions from the panel or any, then we can take it now. So I think there are no more. So thank you so much. And with that, I think I'd like to conclude this session. And I thank the chairman of session, Professor Rajpal, and all of the speakers of the session and the panelists for taking part in these celebrations. Thank you so much for being a part of this RP Center Day celebrations. Thank you so much.
Thank you so much. Thank you.
Thank you. Thank you.
much.
Thank you, everyone.
Thank you.
Thank you.
Recording stopped.